All right, thank you very much, David. So it really is a pleasure to introduce one of my good friends in the area of tobacco treatment and medicine, Dr. Frank Leone. So go through his record here. Frank got his medical degree from the University of Pittsburgh, did his residency and fellowship in pulmonary critical care at Thomas Jefferson University Hospital in Philadelphia, and also got his master's in clinical epidemiology during that time. In 1997, he became director of the Jefferson Tobacco Intervention Program and stayed at Jefferson until 2007, where he moved to University of Pennsylvania and became professor of medicine there in the Division of Pulmonary Allergy and Critical Care in 2018. Frank is known nationally through many different organizations for his work on tobacco control, including the American Thoracic Society, American Lung Association. He's a member of many national committees, including the National Cancer Center Network Guideline Panel for Smoking Cessation. He's involved in numerous funded research, including national grants looking at nicotine standards for cigarettes, as well as PET lung imaging for oxidative stress in electronic nicotine delivery devices. He's also very involved in the state of Pennsylvania in terms of both the state of Pennsylvania and the city of Philadelphia in terms of tobacco control issues like tobacco practice in behavioral health settings. And I could go on and on. Frank has over 100 publications to his name. He also is he really is, when you think about an academic physician, his patients love him. He's an outstanding pulmonary critical care physician. He's a wonderful teacher and educator. He started a tobacco training program over the past few years. He's obviously well accomplished in research. I have to say, as I was thinking about time, this year marks the 25th year after I helped Frank start the tobacco treatment program at Jefferson, and that's where we first kind of got to know each other. It's amazing 25 years has gone by. I have to say that apart from John Slade, who probably none of you remember on this Grand Rounds here at Rutgers, Frank is probably one of the most influential people for me personally in terms of my interests and success in the field of tobacco treatment. So I always like to thank Frank for that. And we'll be hearing him talk today on integrating tobacco treatment in healthcare settings. So thank you for coming, Frank.
Oh, geez, Mike, that's super nice. Thanks so much for saying all those nice things. I appreciate it. Mike and I do go quite a bit back on this, and our paths crossed sort of accidentally. I remember being at some kind of faculty mixer, and a psychiatrist who would go on to become our friend and colleague approached me and almost attacked me, really. He's like, "You're a lung doctor. You need to help people stop smoking." And I said, "Dude, you're a psychiatrist. You need to help people stop smoking." And we argued with each other about where it belonged until both of us came to the conclusion that we needed to really ask Mike. Mike had just published a paper about stages of change among hospitalized patients. And we said, this Mike is here. He's with us. Why don't we just ask him? We started having lunch together and meeting once every other week or so for like a informal journal club around smoking. And the rest is history. All of us got really engaged and involved, and our careers, our paths diverged, but our interests never wavered. And a lot of that has to do with Mike's enthusiasm early in his career and his ability to really put some ideas on paper and make them publicly known. Back in the old days, smoking wasn't the kind of thing that doctors really thought too much about, but Mike was a pioneer in that way. So thanks a lot, Mike. I appreciate it. And it's an honor to be here with you guys. Robert Wood Johnson is a place where an awful lot of work around tobacco has been done. You mentioned John as a pioneer in the area, but even more recently, the group at Robert Wood Johnson has been very influential in driving the field in various directions. It's really an honor to be here with you guys to talk a little bit about this. So I'm going to go ahead and share my screen and get started with the talk. Let's see if I can find my slides. And okay, I'm going to turn this into a slideshow. Can you see it okay? Give me a thumbs up, Mike, if everything's good. All right, excellent. So my name is Frank. I am a pulmonologist, but I have dedicated my sort of academic attention to the the brain basically, and how the brain really sort of drives our exposure to tobacco, and then in the downstream event kind of creates disease. What I'd like to do for the next 45 minutes or so is really review some of the clinical manifestations of tobacco dependence and the biological basis for the behavior we think of as nicotine addiction. If we understand the biology of it and we understand its major manifestations, that gives us some insight that I think we can use to create efficient and sort of effective office-based intervention strategies. Along those lines, pharmacology is actually an important part of office-based intervention strategies, and I want to introduce you to a new guideline that was published about 6 months ago or so, sponsored by the American Thoracic Society. It's focused specifically on clinicians, specifically facing tobacco in the midst of lots of other issues going on. And then this is an unofficial objective. It didn't make its way to the CME application, but what I'm hoping to really do is really fundamentally shake up a couple of assumptions that are deeply held among clinicians. We've been trained for a very long time to think about tobacco one way, and I feel like some of those assumptions really have limited our effectiveness over time. So we'll talk a little bit about some of that. These are my disclosures. I really don't have anything to disclose to you. I have no commercial relationships. I work at the University of Pennsylvania, and I do get grant funding from national, statewide, regional funding authorities. So this is our sort of archetypal complicated patient. I think of Mary as the sort of prototype of the patient that comes into my office. Um, you know, I made all this up. This is just a picture off the internet. This isn't really a real patient. So I think of Mary as a 65-year-old female. She's got COPD. She's oxygen dependent. She's limited in her ability to get around town as a result. She's dealing with hypertension, so she's on a couple of medications as far as that's concerned. She had a past a small heart attack that kind of weighs pretty heavily on her. She knows her heart's at risk. She doesn't really want to take a lot of extra risks and exert herself. She sees her cardiologist every once in a while, and the cardiologist is always telling her, hey, Mary, you got to get your diabetes under control, and you really have to stop smoking. If you don't stop smoking, you're going to die. And Mary pretty typically responds in the same way. She's got this sort of sheepish, smile. I know I really want to. I'm going to. Okay, I'm going to do it, doc. Thanks so much. Okay, great. And then it just sort of never really comes around. And with all these issues going on, it's not at all uncommon for her clinicians to really focus specifically on the functional impact of the COPD, the hypertension, the heart disease, and the diabetes at the next visit. So we want to talk a little bit about why Mary has a difficult time in the face of all these complications, just simply putting the cigarettes down. And there's 3 ideas that relate specifically to nicotine and its impact on the brain that I'd like to review with you this morning. We're going to talk a little bit about nicotine releasing what I think of as a gratification factor in the brain. It's not so much pleasure as it is gratification, and I'll explain that and talk a little bit about the difference. We want to talk a little bit about the idea that nicotine exposure results in changes in brain function and structure. These are fundamental physical changes in the brain that predispose Mary to continue tobacco use for a very long time. And then finally, I want to talk about the cigarette just a little bit and the idea that the addictive properties of nicotine relate not just to the presence or absence of the drug in the system, but really to the rate of delivery of the drug in the brain. So we'll start with that idea. And we'll say that, look, drugs of dependence usually have a kind of typical pattern of delivery. The substance starts off at a relatively low background level. After administration of the drug, there needs to be a very rapid rise, a very steep slope to a very high peak, a relatively high peak. This concentration change has to be very quick. And then through second order kinetics, redistribution of the drug in the system or whatever, the concentration of drug in the blood has to come down towards a new baseline level. There's this big peak that's very important. And just to show you the cigarette's ability to kind of create that peak, this is a graph of nicotine concentrations in arterial blood derived from two delivery devices. First, I'll call your attention to these closed squares here. This is arterial nicotine concentrations derived by the cigarette. You'll see it starts off at the very low background levels after a few puffs off the cigarette. There's a 40-fold rise in nicotine concentrations literally within a few seconds or a couple of minutes. The brain sees this dramatic change in nicotine concentration, and then through redistribution, nicotine levels return towards a new baseline. And that is in contradistinction to arterial nicotine concentrations produced by a few puffs off the inhaler. The open squares down here start off at a similar low background level, and then you get this sort of anemic little rise, this tiny little bump. It's slower, it's lower, it's not nearly the same pattern of delivery, even though at 30 minutes after the drug has had its opportunity to sort of make its way through the system, that the sort of averaged out concentrations of nicotine are basically the same. So the amount of nicotine delivered was very similar, but the pattern of concentration that the brain saw was very different for the two delivery devices. And that's because nicotine is not just nicotine, is not just nicotine. Nicotine is in the plant in about 100 different salt forms. And so here's a sort of basic nicotine molecule. It's organic. I don't know anything else about it, but it's got these two nitrogen atoms sitting on there. And on the end of one of these nitrogens is an acid ligand that actually hooks up and creates the salt. Well, in the process of kind of creating the cigarette, the industry relies on a couple of things. It relies on heavy metals that are present in the dirt being incorporated up into the plant and being sort of present in the tobacco after it's processing. It adds ammonia, urea, or other basic compounds so that when Mary comes along and applies heat, that heat catalyzes a reaction with the nicotine salt that releases the acid from the salt, and at least temporarily anyway, there's nicotine in the free base form. In the free base form, this nitrogen has these two little electrons floating around on it that are available to bind with other stuff, but are unstable. So when free base nicotine is delivered to the airway, it reacts with water in the airway. This free base nicotine molecule picks up a hydrogen and becomes what's referred to as protonated nicotine. In the protonated form, nicotine can traverse the alveolar capillary interface very quickly, but more importantly, it's actually able to be, there are active transport proteins on the blood-brain barrier that actually pick up protonated nicotine and move it into the brain about 10 times faster than simple diffusion. So this part of the process is exceedingly important in the sort of genesis of Mary's behavioral issues. She's really, by using cigarettes, she's really exposed to the crack form of nicotine, and it shows. So what is the nicotine really doing in the brain, and why is it so important to the brain? Well, we're going to talk a little bit about the place in the brain where nicotine works and what it's trying to do. In order to understand that, I want you to think a little bit about the brain as almost as though you can think of it as two separate ideas. Okay, you can't. It's not real. It's not true. But it helps as a model to think of it as two separate ideas. Up at the top here, I'm going to pretend that this part of the brain is the part of the brain that's responsible for cognition and thoughtfulness. This is the part of the brain that you and I are using right now that's responsible for language and understanding abstract concepts. But deeper in the brain, I'm going to think a little bit about sort of the earlier evolutionary parts of the brain as the parts of the brain that are responsible for instinctive responses to the environment. And so it turns out that under normal circumstances, the outside sensory inputs from the eyes, ears, nose, etc., are all coming into the brain 24/7. And they all filter through this little tangle of nerves deep in the midbrain called the ventral tegmental area. The ventral tegmental area is sort of the first stop on the instinctive processes, the survival instinct part of the brain. The VTA's job is to kind of figure out whether the incoming sensory inputs represent something that is relevant to survival or not. If it's not relevant to survival, it's background noise and the brain doesn't have to pay too much attention to it. But if it is relevant to survival, the brain has to stop whatever else it's doing and really respond to whatever the outside environment is. So the VTA then connects to other areas of the brain. For example, the nucleus accumbens, which is responsible for creating the motivation or the drive to react to the external environment. The emotion parts of the brain, which are responsible for creating the emotional context within which we interact with our environment, and areas of the brain that are responsible for managing learning, memory, and so that you're less likely to do the same thing again. Well, it turns out that the major neurotransmitter system in the ventral tegmental area is acetylcholine, and that the receptors in the VTA, the cholinergic receptors in the VTA, are of a form where they are particularly prone to being tricked by nicotine. These are nicotinic cholinergic receptors. We're very used, as internists, we're very used to dealing with cholinergic receptors below the thoracic inlet. You know, they're on the heart, they're in the lungs, etc. Those are generally muscarinic cholinergic receptors. But in the CNS, cholinergic receptors are nicotinic. And so when that nicotine gets in the blood and the blood goes up to the brain, the nicotine tickles the VTA and in essence creates an artificial or imposter safety signal that really changes the way the brain interacts with its environment. Suddenly, sensory inputs that were coming in from the outside world, like the feel of your easy chair or your environment, your surrounding environment behind the wheel of your car, those did not have survival relevance before the introduction of nicotine into the system. But by pairing up nicotine with those sensory environments, that sensory package begins to develop survival importance. And so when Mary tries to sit behind the wheel of her car and volitionally decides not to smoke at that moment, there's a disconnect. Instincts are saying, complete the picture, complete the picture, complete the picture, even though the cognitive parts of her brain would prefer not to because she got good advice from Dr. Steinberg. So that's really where the conflict comes in, and that's really where nicotine is doing the majority of its work, is in the midbrain structures responsible for survival. Long-term use of nicotine produces changes in brain function and structure. When I first recognized that, I was really struck by that. I'm not sure I should have been, because the whole time I realized that the brain is a plastic organ and its job is to respond to the environment and learn. But it struck me that nicotine had the ability to sort of artificially or maladaptively, I guess I should say, really change the nature of relationships between various areas of the brain that would result in observable changes in behavior, in emotion, in thinking. Um, Actually, in retrospect, it kind of makes an awful lot of sense, but at the time I was really struck by it. And there's a ton of different ways that nicotine really influences structure and function of the brain. Um, it can change the pattern of neuronal arborization. So even though we don't know the mystery behind how the brain becomes the mind, we know that it has to do with patterns of patterns in the brain. We know that it has to do with the way different various cells touch each other and encourage each other to fire or not fire. And so patterns of neuronal arborization are really fundamentally important to the function of the brain. It changes the density of nicotinic cholinergic receptors on various parts of the brain. It changes the sort of expression of certain subtypes of nicotinic cholinergic receptors. It will shift the sensitivity of those receptor ion channels over time. And fundamentally, actually, it changes the expression of certain genes, not only in terms of which neurotransmitters are dominant in any particular cell system, but actually there are two small proteins inside the cell that are transcription factors, and they migrate towards the nucleus of the cell and actually create sort of the long-term effect, the long-term intracellular memory, if you will, of having been exposed to nicotine. It is the reason why after Mary comes off the cigarettes and she's been off of a 21 days, 3 months, 6 months, a year, that she could, still go to a party and still feel that sense of connection to the cigarettes, take a puff off of a cigarette and suddenly go right back to smoking a pack of cigarettes a day. So in essence, what we have is a disorder really not of insufficient motivation to stop, but rather we have a disorder that is characterized by excess motivation to continue. And so it's a disorder of motivational control. On the left-hand side, I kind of represented what I think of as the sort of baseline pattern. This is the no-go condition. There is a modest amount of survival salience that the VTA is picking up on, that there's a modest drive, that there's an appropriate relationship to memory and learning systems in the brain, and that all of those are really moderated by cognitive control mechanisms. But after exposure to nicotine and sort of the effect on balance between instinct and cognition, there's an excess or abnormally amplified salience to otherwise irrelevant incoming signals. There's an increased efficiency of drive mechanisms in the brain. There's an impact on learning where some patterns of connections are amplified, others are diminished. And those, at least relative to cognitive control mechanisms have been diminished by what's going on in the instinct part of the brain. And so no matter how much Mary really wants to quit smoking, the instincts underneath all that cognition are pushing her in the wrong direction. And so if this is a disorder of motivational control, an easy way to think about that is that this is a compulsive disorder. I'm not saying that this is obsessive compulsive disease. I'm saying that this is a situation, a syndrome that is characterized by compulsive instincts inside Mary's head. So how does that represent itself? Well, Mary's not exactly ready, willing, or able to stop, no matter the fact that she wants to change. She's not quite ready for change. She's hesitant about making any particular move. And so the experience is actually quite universal among clinicians. We'll talk to Mary and her head goes, yes, yes, yes. Okay, we'll put the nicotine patch on. Oh, what if I need a cigarette while I'm wearing the patch? That whole hesitancy is really about the imbalance between cognitive, really desperately wanting to quit, but also having this sort of internal instinctive desperation not to quit. And I remember this quote actually was really interesting to me. It came to me from a respiratory therapist so many years ago. She said to me, I desperately want to quit smoking, but I don't really want to quit smoking. And that idea of having two opposing goals at the same time is referred to by the psychologist as ambivalence. Ambivalence doesn't mean you don't care. You can care very deeply, but you care in opposite directions, and so you're stuck. And when in the face of ambivalence, we've been taught that it's really a matter of balance between motivations and disincentives. And as a consequence, in school, we've all been taught that the way we're supposed to do this is by increasing the motivational value, right? We're supposed to say things like, oh, Mary, you're going to have another heart attack. Or, oh, Mary, I'm worried about your lungs. Oh, Mary, we've been working on this a long time. What do I need to say in order to get you to stop smoking? But really, the truth is the truth about what we're dealing with is that the balance between cognition and instinct is broken. It's broken, that the disincentives for stopping, for creating change are huge, they're visceral, they're instinctive, and they're about survival. And so we're in a situation where we can motivate like crazy. We can say things like, I'm not going to operate on you unless you stop smoking. And yet that might not have the ability to really fundamentally resolve the disincentives for change. All we might be doing is creating pressure in the system, which paradoxically ends up pushing Mary closer to her cigarettes. So in the office, what I want to actually start talking to you about, we're going to talk a little bit about pharmacotherapy in order to help get this done. But the first idea I'm going to introduce to you guys that may be foreign is I want you to in essence, divorce the notion of clinical outcome, the i.e. the quitting, from the process of creating change, right? You're going to focus specifically on the ideas of how change is actually produced without really worrying too much up front about whether or not Mary's going to quit smoking. That's the goal. That's where we're heading towards. That's what we're always driving at. But in the clinic for today, in this moment, during this visit, you're really focused specifically on the process of change. And the first thing to think about is that the process of change is not about increasing motivation, but by relieving disincentives. And so, as opposed to sort of some of the earlier work where we were encouraged to essentially amplify the negative effects of continued smoking, what we believe that one of the things that keeps people locked into this ambivalent trap is actually that pressure to achieve the goal before they're sort of in the right mental state to achieve the goal. So we start by relieving disincentive. And on a separate day, we can talk about the sort of psychology of relieving disincentive. But I think for today, the best thing for us to do is really focus on pharmacotherapeutic approaches to relieving disincentive to change. All right. So this is by way of background, okay? We did this study a long time ago where we asked a bunch of primary care clinicians. We wanted to understand what the factors were that influenced their decision whether to treat or not treat. And in the literature, you know, it's all about, I don't have enough time, I don't know enough about counseling, I don't get paid for this stuff, etc. Those are kind of the survey responses, but we didn't really feel like it made a lot of sense because time is not normally the thing that keeps us from dealing with diabetes or hypertension. I don't have enough training is not normally the thing that keeps us from learning what we need to understand about diabetes or hypertension. So we thought there might have been some other underlying factors. And so what we asked these primary care doctors to do was a test similar to like when you go to the eye doctor and the eye doctor says, okay, is it 1 or is it 2? Is it 2 or is it 3? Is it 3 or is it 1, right? You get a dichotomous choice and you have to pick the one you like better. And by doing that over and over and over again, you kind of get a sense of which of the lenses are making the biggest impact. What's the best balance between diopters and stigmatism correction? So we did the same thing. We said we pretended that we had all these various smoking cessation interventions, office-based interventions, but they varied in terms of efficacy, level of reimbursement, and time it took in order to accomplish them. And so we went through all these options. Is it A or is it B? Is it B or is it C? And over time, we realized that by you sort of kind of figure out with a little bit what's the parameter that influences decision making the most. And overwhelmingly, the parameter that influenced decision making was efficacy of the intervention. Now, in the literature, interventions were, we've proven that these interventions are effective over and over and over again, yet the perceptions of efficacy were much lower than what the literature would have suggested. So the next step was to figure out why. Why do clinicians really underestimate the efficacy of tobacco dependence interventions? And we identified what we think of as 4 cardinal biases. There's availability bias, where recent or memorable events actually hold sway in our minds. We remember that one patient that we were desperate for Mary to stop smoking. She wouldn't, she couldn't, she didn't, and then she died. And that actually sticks in our head and influences our decisions that moving forward. There's focusing effect bias, where Mary's hypertension, her COPD, and her diabetes need to be dealt with today. And so they grab my attention more than tobacco, which can be dealt with tomorrow. There's impact bias. I imagine that if I bring up smoking with Mary, I'm going to have to hear about her relationship with her mother, and we're going to have this adversarial relationship, and it's going to undermine my therapeutic ability with her diabetes, etc. And there's finally omission bias. I know that Chantix stuff works pretty good, but I heard it's got side effects, so I'm not going to do that. Like this sort of sense that um, accepting the risk of inaction is preferable to accepting the risk of action. Oops, sorry, team. And so what we did was the next thing was we said, okay, well, guidelines actually just really represent an awful lot of large set of information that is really um, sort of a summary of the evidence that's available. What we really wanted to do was kind of create a clinical path that could be conceived of as essentially a universal clinical path. I'm sure that there are patients for whom this clinical path does not apply. I know that to be a fact, but what I'm trying to say is that clinicians need sort of a baseline way of thinking about a pathway forward, and then with variations from there. So to create that or to identify that universal clinical path, we said there are a few questions that keep coming up in the clinic. What's the initial medication choice that I should make 90% of the time? Which is the go-to to start with? Are there some potential modifications I can add on to that go-to that are going to make it more effective? Are there important patient level moderators that I need to be aware of? And we chose 3. We said there are often patients who are not interested in approved therapies. They'd rather do the electronic cigarette or something like that. Um, that there are patients with a history of mental health or substance use disorder that I have to worry about making things worse. And then there are patients who are ambivalent about not smoking, folks like Mary, who are just like, I'm not sure I want to quit smoking. And that's a pretty common clinical circumstance. And then finally, let's just say we do start treatment. How long should we continue it to maximize its effectiveness? So the ATS went through this process and actually came up with a bunch of what we think of as useful clinical advice. So the first couple of questions really look to see what's the optimal controller. And question 1 compared varenicline to patch. There were 14 randomized trials that gave us information on about 3,700 pooled subjects. Varenicline does better than patch does as an initial treatment. And so the idea here is that if you take this relative effectiveness, this relative risk of 1.2 or 1.4 abstinence favoring varenicline and apply that to 1,000 patients treated, you can expect to have 40 additional patients stop smoking if you start with varenicline. So we made a strong recommendation favoring varenicline over patch. Now, what we did then is we said, okay, well, cool. So varenicline is better than patch. Is varenicline also better than bupropion? There were 7 randomized clinical trials, gave us information on about 5,600 pooled subjects. We did the same thing. The relative risk, 1.3 or 1.4 favoring varenicline. Apply it to 1,000 treated patients. You can expect to get 147 additional patients to stop smoking if you choose varenicline over bupropion. So we said, well, for most situations, then varenicline would be the optimal controller, and clinicians should at least start by thinking about varenicline first, which is really one of the assumptions that sort of got shaken up. We're starting to shake up some common practices here because most of the world thinks of varenicline as kind of the final choice. Patch first, bupropion maybe, varenicline last, only if necessary. And we're saying, you know what, just go with the stuff that's most effective. Then the next question was, well, if varenicline is the optimal controller, can we amplify its effectiveness by adding patch? Here's another assumption that runs counter to common sense. Varenicline, its mechanism of action is to work as a agonist antagonist of those nicotinic cholinergic receptors in the VTA. And so when it was first introduced, the notion was that adding nicotine to varenicline was probably counterproductive. It wasn't the kind of thing that was going to do anything. We were already blocking the receptors. Well, it turns out that common sense isn't always correct. There are 3 randomized clinical trials that gave us access to information on about 800 pooled subjects. And look at that. It turns out that is a 36% improvement in abstinence in effect at 6 months if I add the patch to varenicline. sorry, this says favors varenicline, but it should be favors combination. So if I apply the combination to 1,000 patients, I can get another 105 additional patients to stop smoking on top of those that would have quit smoking using varenicline alone. So we recommended using varenicline plus patch. Our next question really dealt with the idea of the electronic cigarette. Most of you guys are familiar with the electronic cigarette. Just briefly, these are devices that are designed to aerosolize an organic solution that contains nicotine, flavorants, and something called humectants. These are the portion of the solution that give the aerosol the appearance of smoke. And people inhale these deeply. They inhale them very frequently. There's really, it's Wild West out there in terms of what's actually inside that solution. And so we said, well, let's take a look and see whether maybe they're as effective as varenicline. I'm not sure. Well, there was really very little direct evidence on the comparison between a varenicline and electronic cigarette. So we did something called a network meta-analysis of 8,800 patients. What we did was we took trials that compared varenicline and patch and trials that compared e-cigarettes and patch. And then the statisticians did a bunch of fancy math and came out with low certainty evidence, but at least suggesting that there's not enough evidence yet to really hang your hat on the effectiveness of varenicline. But what you can hang your hat on is the serious reduction in serious adverse events. There's a big reduction in serious adverse events if you use varenicline compared to electronic cigarettes. So we made the recommendation to stick with varenicline because electronic cigarettes result in all kinds of airway symptoms, cardiovascular symptoms, etc., that varenicline does not. And so we dealt with the sort of reluctant patient last. We said, okay, so here's Jane. She's a 29-year-old female. She has sickle cell disease. She's had acute chest on a couple of occasions in the past, was intubated. She smokes 30 cigarettes a day. And when you talk to her about putting her cigarettes down, she says something that actually makes sense. She says, Dr. Steinberg, the truth is that the cigarettes, I know they're bad for me, but they help me manage my stress. That keeps me out of crisis. And when I'm in crisis, they really make a big difference in my pain scores. So I'm not sure I want to give them up. I don't really know what to do. And so that you can't just tell her to stop smoking and hope for the best. You got to really sort of help her feel more empowered to put the cigarettes down. So we did a question where we asked, should we pre-treat patients like Jane before they're ready to stop, or should we wait for her to say, I'm ready to stop? There were 4 randomized clinical trials that allowed direct comparison of about 1,200 or so, 1,300 pooled subjects. Look at this effect size of pre-treating. 2.5 relative risk of pre-treating with varenicline compared to, or pre-treating period, compared to waiting for her to say, I'm ready to stop smoking. And depending on which of the outcomes you use, you can expect somewhere upwards of 170 to 300 additional patients to stop smoking per 1,000 treated. Now, we felt like this was huge because our clinics are packed with smokers who are not ready to quit smoking. I mean, if there's one thing we have zero shortage of, are people who smoke who are not quite ready to stop. And instead of waiting for them to say, I am ready to stop, if we simply treat them with medication, their readiness improves over the course of 3, 4, 5 months till those patients will actually go ahead and put the cigarettes down on their own with only minor modification or minor counseling. So that's why, in large part, this is one of the reasons why we suggest that folks really divorce the clinical outcome, your interest in achieving the clinical outcome of cessation from the notion of treating or dealing with the obstacles to moving forward. Think about those two things differently, process versus outcome, and create the process for change really results in a big difference. Now, this is something that actually folks at Robert Wood Johnson have taken the lead on nationally and have really had a big influence on creating change in the setting of patients with mental illness, whether it's serious mental illness or substance abuse. Um, the prevalence of smoking in these populations is huge. And even though the absolute numbers change from estimate to estimate, the pattern is always the same. The more significant or more serious the thought disorder is, the higher the prevalence. And the more serious among patients suffering the same problem, among a population of patients suffering mania, uh, prevalence of smoking changes based on the severity of the illness that they're dealing with. So there has to be some kind of relationship, and we've often thought about the nature of the relationship as these folks are kind of treating themselves, trying to keep their symptoms under control. The truth is, we're not 100% sure which is the chicken and which is the egg. It seems like there's an emerging body of evidence that suggests that exposure to nicotine actually increases the risk of developing depression, and that removing nicotine from the system may have as large an effect on things like anxiety disorder, depression, um, behavioral quality of life indices, uh, as as a medication would. So we think that actually nicotine may be in part responsible for the experience of serious mental illness, or at least the severity of the experience of serious mental illness. As a consequence, these folks suffer a 20% shorter lifespan. Their risk of cardiovascular and respiratory diseases is off the charts higher than the risk in the general population. But there are lots of hidden costs of sort of allowing, or in some ways even promoting, tobacco use in this population. And Mike and Jill Williams were the first really to document exactly uh, what the uh, numerical cost was on income. This was this was a while back, but this was before cigarettes went up to $10 a pack in the Northeast. Patients with mental illness were spending over 27% of their fixed income on tobacco products compared to every other cost that they had. And so when you have a limited resource and you're forced to dedicate an increasing proportion of that limited resource to tobacco, tobacco gains relevance, gains value as a contraband product in that population. So sustaining violence, homelessness, drug abuse, sexual abuse, all around the availability of tobacco. Tobacco is currency that actually has a huge social, environmental impact on patients with mental illness. So we decided we would sort of summarize the data that was available. Should we use tobacco treatment medications in patients with behavioral health problems? The question was, should we use Varenicline or patch? Generally speaking, the Varenicline worked better, and we made a strong recommendation in favor of Varenicline over patch. If you treat 1,000 patients with Varenicline instead of the patch, you can get 36 additional patients with severe mental illness. Now, the nice thing about it is that the adverse event rates were actually, let's see, it's down here on this line down here. These are the serious adverse event rates. There was no difference in serious adverse event rates compared between using patch compared to Varenicline. And then finally, how long should we continue to treat? If we start Mary on treatment, how long should we continue to treat it? The general gist of treatment is it 3 months or 6 months? The label says 3 months. The data we felt said 6 months. So we compared the two, and extending the duration of therapy to at least 6 months should be expected to create an additional 53 people who put the cigarettes down over and above what you get from treatment at baseline. So there are several practical implications, several things to think about in practice from a systematic point of view. In practice, we should not really be thinking about Varenicline as a last line. We should be thinking about Varenicline as first line. And not necessarily requiring nicotine or bupropion failure. That's true personally. That's also true from sort of an insurance coverage programmatic point of view. We'd like to see more plans cover varenicline upfront. Treatment should be made available for patients for more than 3 months duration. That doesn't force clinicians to treat everybody for 6 months or more, but it should give clinicians the flexibility they need to decide at the 3-month mark, is Mary ready to come off of her support medications? Is the total therapeutic value of this drug, have I accomplished what I need to accomplish? Should I go for a little bit longer? We've talked about some of these already. We want to treat the compulsion before the patient is ready to quit. My favorite story is a book that came out. I can't remember the author's name at this point, but she was a young woman with young children, a husband. She smoked. She knew it was bad for her. She wanted to quit. She convinced her family to handcuff her to the radiator in her bathroom for a month, for 30 days. And they would bring her food there, and they would release her for 30 minutes each day for, PT time or whatever. And she imagined that 30 days without smoking, and she would be done. But instantly, as soon as they uncuffed her, her first trip was to the local convenience store to pick up a pack of cigarettes. We have to actually make sure the compulsion is cared for and controlled, as much or more than whether or not the actual behavior is foregone. Oh yeah, and then finally, adding nicotine to varenicline amplifies the effectiveness of varenicline despite the proposed mechanism of action of varenicline. And then finally, a history of or current problems with behavioral health disorders, including substance use disorders, should not preclude the use of varenicline in that population. I'll summarize with these 3 points to remember. Smoking is the behavioral manifestation. Another word for that is cardinal sign of a disturbance in brain biology induced by exposure to nicotine. In other words, we shouldn't really be thinking about smoking as the antecedent condition for diseases of other organs. What we should be thinking about is when we see smoking, we should think about that as the cardinal sign of a disturbance in brain biology. The cardinal symptom of this disturbance is the compulsion to smoke. Compulsive disorders always manifest themselves as reluctance to change. Reluctance to change is not a problem for us in dealing with Mary. Reluctance to change is the problem that we're helping Mary deal with. And then in order to manage that reluctance, pharmacotherapy is a very useful tool in helping to resolve the apprehension associated with compulsion when it's used correctly. And by correctly, I mean use it before Mary's ready to quit smoking, use it for longer than you thought you might need to use it, and be willing to explore the effectiveness of various combinations of medications in order to achieve the effect you're looking for. And I guess that puts us at about 45 minutes. I'm going to stop there and give us a little time to manage any questions that have come through. I hope that in some small way this talk was useful to you guys.
Yep. Thank you so much, Frank. That was wonderful. Who would have thought that a pulmonologist would be so skilled on the brain and behavior? That's very impressive. You've mastered 2 or more organs in your career. We have a number of questions already, and I'm going to try to keep up with them. So, number one, I think it was wonderful how you spent as much time as you did talking about understanding the brain effects and how the behavioral and the compulsion of this. I think as clinicians, many of us get frustrated, like you said, with our patients. We can't even comprehend how this person can walk into my office, a week after a heart attack and is still smoking, or just got a diagnosis of lung cancer and is still smoking. So I think you've really helped, hopefully helped clinicians get over some of that frustration. Somebody asked about visceral bias and countertransference, and kind of how some of these things that you described, I want to make sure I get the question right, how they affect when we deal with our patients, our attitudes and our decision making in terms of kind of some of these biases, and thinking in comparison to prescribing pain medications to a
Yeah.
person with a history of opioid abuse. So can you comment on kind of how those biases might come into play with tobacco treatment?
Yeah, that's a great question. My God, you have to invite me back next year to talk a little bit about this topic in particular. So we were interested in this this notion of fundamental attribution error. Fundamental attribution error relates to the way that humans engage some failure in someone else. So my favorite way of thinking about it is I'm driving on the parkway and somebody cuts me off. That's a failure. I am going to assess sameness in that person instantly, to the degree that that person, I can associate that person with me, my group, my identity. I will attribute that person's failure to environmental factors. Well, maybe he's in a rush to get to the hospital. Maybe somebody cut him off, whatever. To the degree that I assess that person as other, as different than me, I will assign that failure um, character flaw characteristics. Well, what a jerk. I can't believe he did that. Didn't he see me? And then, hit the horn. So if it's character flaw, the emotion that that produces is frustration, and frustration reduces willingness to help. And we published a study a while back among primary care clinicians across the country. It was 100 respondents. Culpability bias, like the idea that it's the smoker's fault, was off the charts. That compared to dealing with hypertension, everything's the same in terms of technical barriers, how much time it takes, how comfortable they feel with their training, etc. The one difference was in the emotional construct, the emotional impact of dealing with the problem. Frustration was off the charts prevalent in that respondent group. So we feel like this fundamental attribution error based on the way we as a society have approached this behavioral problem, you need to stop smoking, is really limits our effectiveness in the interaction and colors, even in ways that we're not aware of, how we interact with these folks.
Excellent, thank you. Shift to pharmacotherapy. So when you were describing the benefits of Varenicline over nicotine patch, what are your feelings about combination NRT, so patch and short-acting
Yeah.
NRT versus Varenicline?
Right. That actually turns out to be the kicker question. That's it's usually the person in the group who's up on the data around tobacco dependence treatment who says, hey, wait a minute, Varenicline and combination NRT are about equivalently effective. You're right, and that's true. But we had to make the decision about whether or not to introduce that variable to the workflow. And we decided against it. First, for practical reasons. There's only so much money that you have. Second, we felt like if we answered that question the way we felt like the answer was going to come out, that would create a split in the logic algorithm that then would make our guidelines sort of incomplete. So I would say, based on the evidence, go for it. If your patient is reluctant to use Varenicline, if it's not covered under their insurance, if it's not on your formulary, whatever, go with combination nicotine replacement therapy.
Well, thank you. Staying with pharmacotherapy. So for our hospitalist faculty clinicians, typically we would use nicotine replacement like the patch or gum with hospitalized patients. Would you consider using Varenicline in hospitalized patients, both during the hospitalization, and what medication would you prefer to use on discharge?
Right. So the majority of hospitalized patients aren't really suffering what we would typically think of as withdrawal symptoms. There are some who do. There are some who are jonesing for cigarettes even while they're laying in the hospital bed. But the significant change in environment, at least temporarily, puts them in a different mindset. So you'll notice that a lot of people say, I haven't even thought about a cigarette since I got admitted 3 days ago. Whether they think about cigarettes, whether they're jonesing for them or not, starting Varenicline is a good idea. There's good data that suggests that Varenicline, despite the sort of delayed onset of action, has getting all the practical barriers to getting Varenicline in order while they're in the hospital, getting things started, is very useful. And those patients will go on to stop smoking at reasonably high rates. About 30% of those folks will stop smoking post-discharge. What's interesting about starting Varenicline in inpatients is that it doesn't necessarily mean that they'll be able to continue it as outpatients, because of insurance issues, preference, all kinds of stuff. But having started Varenicline on inpatients almost doubles the likelihood that they'll continue something post-discharge. So it's worth it. And then finally, I would say start the Varenicline at baseline for that subset of hospital patients that are saying, I have to smoke, I'm going crazy, or for those folks who you suspect withdrawal is a big part of the issue. Go ahead and put them on a patch, offer them gum or a nicotine inhaler during their hospital stay. It gives you an opportunity to teach them how to use it and to adjust doses and things like that.
Outstanding. Shift gear a little bit. So regarding electronics devices, e-cigarettes, especially in younger people who clearly have more issues with impulse control and compulsivity. You mentioned that's important. What are your thoughts about young people, especially who are using electronic devices, in terms of treatment for them?
Yeah.
What are your thoughts?
Yeah. So, excuse me. Electronic cigarettes actually, in my view, actually the term is too broad. There's a super wide variation in the nature of drug delivery between the devices. And so if you don't think of them in terms of their commonalities, but actually think of them in terms of their differences as drug delivery devices, some of the newer generation devices are better at producing that peak than cigarettes are. There's a higher proportion of free-base nicotine coming out of many pod devices, like the sort of ones that I showed you that look like a USB device, than come out of cigarettes. Those kids who are exposed to these devices are creating real change in their brain that will have long-standing impact in terms of emotion control, impulse control, their risk of developing depression and anxiety disorder later on in life. It's real. And these are harms that folks who tend to have conversations about the harm reduction potential don't really think too hard about, right? It's like, as long as we're preventing lung cancer, we're decreasing harms. Well, harm isn't like that. It's not a single unitarian thing that we're trying to produce. We're trying to give people a better chance at better life on a number of different axes. So my sense is that they should have been regulated a long time ago, and access to these devices should have been a lot harder. We probably did the population some overall harm in the
Gotcha.
process.
I know we're at 9 o'clock. I have a couple more questions. So if people need to leave, obviously you can leave. Feel free. But I'm gonna since I have Frank here and it's so uncommon that I have a hold of him, I'm gonna ask him the last couple questions. Somebody said that follow up in the outpatient practices is often challenging for us, especially for tobacco treatment. So
Yeah.
can you comment kind of about the model of delivering tobacco treatment in clinical settings versus having a standalone tobacco treatment center or program?
Yeah. So you guys don't have to do what I do, but what I would suggest for the typical clinician, whether you're an internist, a pulmonologist, or otherwise, is to really think about this problem the same way you would manage two concurrent presenting problems that show up in your office. So let's pretend you're the internist. Mary shows up with hypertension and diabetes. You ask her a couple of questions about her COPD. You put it down as, I want to make sure everything's okay. I'm going to need to get PFTs at some point. But you adjust her insulin and you adjust her antihypertension. And then you say, Mary, I need you to come back in 4 weeks. And at that visit, we're going to, you write in your chart, I'm going to deal with the COPD. I would say in practice, you can't do this stuff all, it's not practical to think about getting it all done on every visit. But not being able to get it done on every visit doesn't mean forget the problem exists. It means bring Mary back a month from now where you're just going to check in on her diabetes and hypertension. And now for the next 7 minutes, we're going to talk a little bit about tobacco. So follow-up is difficult. Our schedules are packed. But if this problem exists on the problem list, then it begins to influence your decision making in terms of frequency of return and how much time you need to dedicate to Mary's visit moving forward.
Outstanding. All right, the last question I'll trouble you with has to do with duration of treatment. So thinking about Varenicline, nicotine replacement, typically we would use these medications for 3 months, maybe 6 months. Is there any harm to continuing them for longer periods of time? What do you generally see yourself doing in practice?
Yeah, there is no harm to using them longer. Our practice is 6 to 12 months. So when people ask me, how long should I expect to be on this? I say 6 to 12 months, no matter how good you're doing. Even when you quit smoking, you're going to be on it 6 to 12 months. Two things there. First, people tend to think about the utility of these medications as the stopping of the smoking. But as clinicians, we think about the utility of these medications as treating and resolving and helping to resolve the underlying compulsive disorder. That takes a lot longer. Those patterns take a lot longer to resolve. So we have to make sure that Mary understands it's not just about the stopping, it's about the staying stopped. So 6 to 12 months. The other thing about 12-month duration is that the literature suggests that 12 months is not a whole lot more effective than 6 months. However, all of those observations have been the difference in effectiveness has been about adherence. And so if you're going to continue medication for 12 months, you can expect them to be effective if you can help Mary remain adherent to the medication that long. So that means, all right, Mary, I need you to come back in 2 months. All right, Mary, I need you to come back in 3 months. Putting yourself on her schedule is rule number one for helping her stay adherent to the medications.
Outstanding. All right, well, we've gone over. Thank you very much, Frank. I think people really enjoyed this talk. The topic is wonderful, and your delivery is outstanding as always. So,
awesome.
I guess, David, anything else we need to wrap up? All right. So if people, I don't know if Frank wants to stay on, but if you want to stay on and for the next hour, but otherwise, everybody take care.
All right, guys. Thanks very much for inviting me. I enjoyed it very, very much. Thanks a lot. Take care.